CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Okay, thanks, Sean, and good afternoon, everybody. My name is Amy Salmon. I'm the Associate Director at CHÉOS and also a scientist and program head for knowledge translation. And it is my very great pleasure today to introduce our colleague, Dr. Joseph Puyat, to speak on his work today. Dr. Puyat is an assistant professor in the UBC School of Population and Public Health, and he's a scientist and research methodologist at CHÉOS. He obtained his PhD in Population and Public Health from UBC, and his previous training includes an M.Sc in Healthcare and Epidemiology, as well as an MA in Social Psychology. In his previous research, Dr. Puyat used linked health administrative data from the province of BC to study gaps and disparities in depression care and to examine whether the introduction of physician incentives impacted the magnitude of existing care gaps and disparities in this area. In his current work, some of which I'll speak about today, he's exploring how the prevalence and burden of depression at the population level can be reduced over time by ensuring that treatment approaches are tailored to individuals' characteristics. He's also looking at reducing or eliminating treatment disparities, as well as promoting community-based activities that have therapeutic and preventive effects. I know we've all been looking forward to Dr. Puyat's talk, and it's my pleasure to pass the baton over to him.
Thank you, Amy, for the introduction and also for the continued support. Dr. Amy Salmon has been a long-time contributor and supporter of this project and other projects that I have. So I really appreciate the introduction as well as the support from previous years. I would like to start by acknowledging that I currently live and work on the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I have no conflict of interest to declare, but I do receive a salary support from the Michael Smith Foundation for Health Research as a scholar for the research program that I'm currently leading, which is looking at ways and means to reduce the burden and prevalence of depression through community and home-based activities and resources. Also, the project that I will be talking about and discussing today is was funded by a knowledge synthesis grant from the Canadian Institutes of Health Research. Neither the Michael Smith Foundation for Health Research nor CIHR had any role in any aspect of the research that I have conducted. And all inferences and opinions that I would be expressing here are mine and may not reflect the opinions or policies of MSFHR or CIHR. Also, I'd like to mention that no public health guidelines were disregarded when any of the pictures that I will be showing were taken. My plan for this presentation is to share results from a study that we conducted last year regarding mental wellness during the COVID-19 pandemic, and also share with you some of the work that we are continuing to do, which is work that is very much in progress. So I would really appreciate any insights or comments or suggestions you may have or that you may be able to share today. Specifically, I will be drawing from the results of a rapid review that we completed last summer. The rapid review was published in PLOS One. So if you're interested in a more detailed presentation of the results or the discussion of the findings, I would invite you to get a copy. You can either download the PDF from the website. I provided the link at the bottom of the slide, or you can just email me and I'm happy to forward you the PDF. I don't know what your recollections of how you were doing during the early days of the pandemic last year. For me, I remember that sometime in the middle of March, through the first weeks of April when a lockdown was implemented, I felt lethargic for several weeks. I was saddened by the abrupt disruption in my daily routine, as well as my disruption in my usual sources of social support outside the home, which is mostly at work. I also bike to work, and that too was disrupted. I even have a planned family vacation to Iceland for a week and a few more days we were planning to spend in Budapest and Prague. So all of those plans were canceled. And like many of us, I just stayed home and did nothing which made me feel lethargic and anxious and distressed. And I wasn't the only one who was feeling that way. In fact, based on a representative survey of about 3,000 Canadians, which was commissioned by the Canadian Mental Health Association, they conducted a survey during the last 2 weeks of May last year. That survey reported that 38% of the population say their mental health has declined due to COVID-19, and 46% felt anxious and worried. 14% have trouble coping, and 6% had suicidal thoughts. There's even a 2% that tried to harm themselves in response specifically to the pandemic. So people were really struggling with their mental health. And this challenge is even more severe among people with pre-existing mental health conditions. We also conducted our online survey last year just to examine the connection between non-work related activities and symptoms associated with depression, anxiety, and stress. Unfortunately, we did not get a representative sample. We tried, but we didn't end up with a representative sample. What we ended up with is a sample of individuals who are relatively affluent than the general population. But again, the same pattern holds. So even people with presumably more resources, so we see the same pattern of experience with various mental health challenges. So about 16.3% met criteria for moderate to severe anxiety, about 19% met criteria for moderate to severe depression, and 37.7% experience high levels of psychological distress. So yeah, elevated levels of symptoms of mental disorders were found even in this relatively affluent sample. And this really highlights the need for better mental health services and support during pandemic, and perhaps in future public health emergencies. Regrettably, as the number of people who could benefit from mental health services increased during that time, the availability of in-person services has decreased significantly. We do have telemental health services and e-mental health services available, and these have been proven to be effective for quite some time now. And to a great extent, they do help fill in some of the gaps that the pandemic has amplified. However, many of the high-quality e-mental health services are not really that accessible. When you try accessing them. I did. Many can only be accessed through private insurance or through one's employment, or require contact with a primary care provider. So barriers exist even with digital mental health. And that is why last year we sort of thought about, what other support and services can the population rely on? And that's why we conducted this rapid review to identify evidence-based approaches to mental wellness that can be done at home, preferably without or minimal intervention from a professional service provider. To those of you who may not be familiar with rapid review, I would offer this definition from the Cochrane Methods Group. So a rapid review is a form of knowledge synthesis that accelerates the process of conducting a traditional systematic review through a streamlining or omitting various methods to produce evidence for stakeholders in a resource-efficient manner. So a rapid review in many ways contain the same elements you will find in a systematic review, except for some procedures that have to be streamlined in order to provide a timely input to stakeholders who needed to make a decision or some policies. At the time that we conducted the rapid review, Cochrane was still in the process of formalizing their recommendations. And there are also other guidelines that exist in the literature. And depending on which guidelines you refer to, recommendations vary. So you will notice some variations in the review process described in many rapid reviews published today. For us, though, what we did was we had at least 2 review authors perform the title and abstract review screening. When it comes to the full review, we predetermined that 25% of the eligible records will be reviewed by 2 authors, and the rest will be reviewed by 1 review author, with the second review author conducting full reviews on all excluded studies. Normally, these steps are conducted by 2 reviewers in a full systematic review, but in our rapid review, we did these changes in the procedure just to be able to expedite the process. And finally, all assessments of risk bias were performed by only 1 review author. So those are the streamlining procedures that we implemented in our own rapid review. In the rapid review that we conducted, we have specified the following inclusion and exclusion criteria. We were specifically looking for intervention studies or studies that examine the impact or influence of certain activities on mental health. And the study should also should have used a standardized measure for mental health outcomes. It could be one of those standardized tools for measuring psychological distress, symptoms of mental illness, or symptoms of distress. And finally, the studies must also be done in contexts that increase or lead to social isolation, such as in public health emergencies, or in incarceration, or during scientific expeditions. We excluded studies that were not published in English, and we also looked at only studies that were published between or from 2000, just because we were interested in how people were responding to modern day epidemics. One of the important exclusion criteria that we specified is that the study must not be focusing on medication or formal psychological therapy, just because during public health emergencies, this may not be freely available. So those are the criteria that we have set out to use for the study as we screened and reviewed the literature. If you are thinking of conducting a rapid review, I would strongly encourage to be familiar with this international Prospective registry for systematic reviews. Its registration is free of charge, and the registry is maintained in the UK. From our experience, the support staff is extremely responsive. It's always a good idea to search the database first to determine if a similar or related review has already been done or is currently underway. Also, peer reviewers like to see prospective registration of review protocols when you submit the manuscript. So we had a professional librarian on the team who helped with the design and execution of the search strategy. The search strategy was executed on May 28, 2020. And we ran the search strategy on 5 bibliographic databases plus 3 other sources, mostly information sources on gray literature. The search identified a total of 1,781 potentially eligible records, which we screened and assessed for inclusion in the full review. In total, there were about 16 studies that were included for full review. There were also about 17, exactly 17 related qualitative studies, so which we have excluded in the synthesis of quantitative studies. These qualitative studies were reviewed separately by Dr. Amy Salmon and her team, primarily Ms. Sarani Fernando and Ms. Mai Berger. The studies that made it through the full review, 8 of them were randomized clinical trials, and 8 were non-randomized studies of intervention. There were 2 activities with more than 1 studies in each, and those are the exercise, which has about 10 studies, and yoga. There were 3 studies that we found, and we found 1 study for each of those activities, like progressive relaxation, listening to relaxing music, and solitary religious activities. The mental health outcomes that were investigated in these studies include anxiety symptoms, depressive symptoms, psychological distress, and feelings of hopelessness. The settings were prison, mostly, and 1 hospital and 1 community setting. I have to note that most, if not all, except for 1 study, most of the studies were from prison, and this may limit the generalizability of our findings, given potential differences between the general population and people who are in prisons. Before I present the results, I'd like to note that we converted all quantitative measures of the effects of the activities into a standardized value called effect size. We did this to get a better sense of the evidence across studies. Generally, the higher the value of the effect size, the stronger is the effect. For example, a value equal to 0.8 and higher is considered in the literature to be large, and an effect size equal to or less than 0.2 is considered small. And values between those 2 cut points are considered to be moderate. And just to provide some sort of a reference point, I would like to use this figure from a paper that summarizes effect sizes for common pharmacological treatment. You can, the study is available online if you're interested. The author supported an effect size of 139, for example, for medications used to treat stomach acid, and that is considered to be a large effect. In comparison, antidepressants in this region here, the effect size that has been reported is around 0.38, which is considered to be moderate. I should note that in the study that we conducted, we did not pull the results from the 16 studies because of large differences in the way the studies were conducted. Also, or instead, we followed guidelines specified by the group that created the guidelines for performing synthesis without meta-analysis. Now on to the first set of results, which pertain to the impact of exercise on anxiety and depression or depressive symptoms. We found 5 studies that reported exercise to have a positive impact on anxiety symptoms, or that exercise was associated with a reduction in anxiety symptoms. The effect sizes ranges from small to large. These are the small effect sizes we found from those studies. And this is one of the biggest one. In one study, two types of exercises were compared, the high intensity and cardio plus resistance training. No substantial differences were found between the two types of exercise. Most of the studies had low sample sizes, so some of the effect sizes were very imprecise, as you can see from the tails of the confidence interval crossing the boundary identified by the 0 vertical line. Exercise had a similar effect on depressive symptoms, although the effect appears to be more consistent and pronounced. As you can see from the lower tail of the confidence intervals, all of them are above the 0 vertical line. And most of the effect sizes are either at or within the region called large. So basically the impression that you would get from these studies is that exercise had large impact on depressive symptoms. Again, no substantial difference between high intensity training and cardio plus resistance training. In case you are wondering what is with exercise that produces these effects, from the literature that we have examined, they attribute the anxiolytic and antidepressant effects of exercise to a number of physiological changes that happens during exercise, particularly involving those neurotransmitters such as serotonin, norepinephrine, and dopamine, which all play an important role in mood regulation. Exercise also acts as a form of distraction from stressful situations, which helps gives us a sense of control. And also because exercise increases the feelings of vigor and over time makes people feel stronger and look younger, one of the nicer side effects of exercise. It can enhance self-esteem and self-confidence, which eventually contributes to improved mental wellness. Now on to yoga. We found only 3 studies that examined the effects of yoga on symptoms of anxiety and depression. These studies found yoga to have some effects in reducing symptoms of anxiety and depression. The effect, however, is not consistent and most of the time imprecisely measured. But just looking at the point estimates, there do seem to be a trend towards beneficial effects, except that the sample sizes for these studies are small, and we just couldn't, or those studies just couldn't get a more precise measure of the effect of yoga on depression and anxiety. What's with yoga that could potentially produce a beneficial effect on our well-being? From the literature, again, the practice of yoga has been associated with breathing and relaxation, affecting many systems in our body simultaneously. And many people are saying that over time, the practice of yoga leads to improvement in autonomic responses to stress and coping behaviors. And this is the last set of results from the rapid review that I wanted to highlight. And the results are based on three separate studies that investigated 3 different types of activities. The first 2 studies involved the use of progressive muscle relaxation technique and listening to relaxing music. For those who may be unfamiliar with progressive muscle relaxation, this technique involves tensioning certain muscles of your body for a few seconds, maybe 5 seconds, and then releasing those muscles for a longer period of time, maybe 15 seconds. and then repeating the process for all the muscle groups, working slowly, either from up or down. This particular study on progressive muscle relaxation was the only studied was the only study we found that was conducted specifically during the COVID-19 pandemic, and the effect that was reported, which is um, quite large, or in the large region there. The effect was obtained after 5 days of performing the technique for 30 minutes, 30 minutes a day by patients who were hospitalized with COVID-19 disease. The other study, again related to relaxation, investigated the effect of listening to music, also reported a large effect size. And the interesting thing about this study was the choice of relaxing music. The music selection was based on what the participants in the study found to be relaxing, and not on a predetermined type of music. Although in the existing literature, there is some evidence that certain types of music, certain properties of music can be inherently relaxing. But for this particular study, it's music that people would regularly listen to and that would find really relaxing. The effect, the large effect that was reported there, that was obtained from listening to relaxing music for 45 minutes 3 times a day for a total of 3 weeks. And finally, the last study we reviewed investigated the association between solitary religious activities and symptoms of post-traumatic stress disorder. This is the only study we found that reports a negative association. It's interesting because the investigators found that people who self-reported engaging more frequently in religious activities that they perform outside the context of a church or an organized event, they are more likely to report symptoms of PTSD. The examples provided include reading religious literature alone, praying alone, or any forms of religiosity that is practiced outside or independently of a church or a religious organization. So the main takeaway from the rapid review is that there are activities that can help promote mental wellness and resilience during the COVID-19 pandemic. These activities can complement mental health services being produced or provided through online platforms. We do acknowledge that none of the studies we reviewed were actually conducted in home settings, although we argue that they can be done at home. Most of the studies were reviewed, that we have reviewed, were conducted in prison settings, which are places characterized by acute lack of resources, lack of mobility, and lack of contact with the outside world, which in many ways resemble the situations many people find themselves in during lockdowns. We are thinking that, if these activities can produce these positive effects on mental health, and this kind of very restrictive and low resource settings, they are also more likely to work in general, or in less restrictive settings. More importantly, we are currently updating the results of the rapid review, following the same procedure that I described earlier. And so far, we have identified additional 23 studies that were conducted, or 22 studies that were conducted during the COVID-19 pandemic. And the results were pretty much consistent with what we have already reported, particularly those results that pertain to the importance of physical activity. We are going to do updates to the rapid review for the next 1 or 2 years, and I don't anticipate finding results that, although I'm looking for it, I don't anticipate finding results that we haven't already reported, given what I've seen so far. The second takeaway is that we need guidelines on home-based activities. Such guidelines will help minimize potential adverse effects that can happen when certain activities are done in excess or perhaps incorrectly. I'm thinking mostly of exercise. Just because it's effective doesn't mean we should be overdoing it. There's potential for harm if we do certain types of exercises. And guidelines would also increase the likelihood that the activities will be optimized to achieve the intended benefits. Another takeaway is the importance of encouraging and supporting the population to perform some of these home-based activities or activities that can be done at home and that can promote mental wellness, in addition to encouraging everyone to support the public health guidelines about staying home and social distancing. It is also important that we also provide evidence-based recommendations on what activities we can engage in and that may have a beneficial effect on us. And finally, an important insight we gained from the rapid review was the finding that there's a great deal of studies that examine the impact of a wide range of activities on mental health. Most of these studies were not conducted in contexts similar to what most people experience during pandemics. Hence, we excluded them in the rapid review. But there's quite a lot of them, and a good source of evidence on these activities are published systematic reviews. And when we were conducting the rapid review, we felt that we came upon many of these systematic reviews, and we felt that now is the time to perform a meta review or a synthesis of this systematic reviews. So that we can come up with some sort of a guideline for various types of activities that can promote mental wellness. And that brings me to the second, to the continuation of our research. And this is what our team is currently doing. We're looking at the strategies that can be done at the population level and outside the context of pandemic or public health emergencies. And these strategies and approaches will benefit, we believe, will benefit everyone, and not just those who are experiencing or living with mental health challenges. We recently received funding support from Michael Smith Foundation for Health Research to continue doing this study. And it's from the Convening and Collaborating Grant. And we are, the two main objectives for the project is one, to come up with a living meta review protocol, and the other one is to hold a speaker series, which will happen between September of this year and October. A living meta review is basically a knowledge synthesis that is posted online and that gets updated on a regular basis, perhaps every 6 months or every year. We still haven't figured that out in terms of what's the best and the optimal way, optimal timing for updating the meta review. So for the meta review, we are hoping to identify published systematic reviews on activities that promote mental wellness. We're looking specifically for systematic reviews, and we will be synthesizing those. and the protocol will describe the specific review and quality assessment procedures that we will do. And we are planning to open the collaboration to as many people as we can, just because we feel that the literature is large. We ran our draft search strategy and we ended up with about 10,000 search hits, which is quite a lot. We haven't, and we will not be doing this for the project. We haven't actually done screening the titles and abstracts, but we will be doing that once we have drafted a living meta review protocol. So the other event is a speaker series. For these events, this will be 4 events consisting mostly of sessions lasting for 3 hours. We will be inviting researchers with the expertise in various activities. We're thinking of inviting researchers who have done a recent synthesis or systematic review on physical activity or exercise. We have some people in mind, but if some of you have suggestions on who we can invite, we would happily welcome those suggestions. We will also be inviting people with lived experience who are comfortable sharing their experiences with those strategies or activities and how they found them helpful in their dealing with the challenges that they're experiencing. And finally, we'll be inviting practitioners who can translate the research evidence into something that is practical and something that participants in the events would be able to implement in their own lives and hopefully help promote their mental wellness. So at this point, I'd like to acknowledge the many people who have, for the past few months, have contributed to the study and are still contributing. And also, I'd like to acknowledge the help of CIHR and the Michael Smith Foundation for Health Research for the funding support. Thank you so much for spending your time, your Wednesday afternoon with me, and I'm happy to stay on for a few minutes to address any questions or to listen to any comments or suggestions that you may have for us.